Good morning, everybody. First of all, I must thank AIOC for giving us this opportunity, and our Chief Instructor, Professor Rajiv Gupta, for giving me this opportunity to talk on this very common problem that all of us face in our day-to-day practice. And we have evolved from bare sclera to the gold standard technique of conjunctival autograph that my colleague Dr. Sunil and Dr. Zahid discussed. But still we have some recurrences. Even the gold standard technique, different studies have shown that there is a recurrence rate of about between 2 to 10%. So can zero recurrence be really achieved? So that is what I am going to talk about, and let us see by the end of this talk where we reach. Moving. Why do we need zero recurrence? Because any recurrent pterygia, it has a more aggressive clinical course, it damages more, it is more difficult to treat than the primary pterygia. It can lead to restrictive strabismus also, and that is why it is always better to prevent the recurrence. So to remove the pterygium is the best opportunity. The first opportunity to remove the pterygium is the best opportunity to avoid all these complications and frequent visit of the patient. As it was discussed, the primary pterygium is basically an elastotic degeneration, but the recurrent pterygium is predominantly fibrotic. And the causes of recurrence are surgical trauma, which we create. We disturb the tenons and it reacts and grows again. There is a fibroblastic proliferation. It is not UV mediated, as the theory has proved that the primary pterygium, the UV plays a very important role, very major role in the development of primary pterygium. Recurrence rate, bare sclera, it touches the roof actually, 24 to 89% different studies, conjunctival autograft 2 to 12%. Amniotic membrane graft has also been used instead of conjunctival autograft, and that was again the reported percentage is 4 to 40% different studies. There is a technique, perfect technique, I will be talking about it, which has significantly reduced the recurrence rate to around 1.5%. So this gold standard technique, excision with ocular surface reconstruction, with conjunctival autografts, with or without amniotic membrane graft. It is a very safe procedure with low recurrence rates and excellent cosmetic results that Dr. Sunil discussed. The causes of recurrence in conjunctival autograft, which is the gold standard technique, is insufficient graft size. If the graft is thick, graft retraction or inversion happens. If there is inadequate tenons resection, if there is incomplete control of the post-op inflammation, and to start with, we had a very higher morphologic grade, very fleshy and very vascular pterygium. So this is the technique. Dr. Lawrence Hurst of Australia is the father of this technique. He developed this technique some 20 years back, almost more than 20 years back, which is called the perfect technique. And the name actually justifies that. Perfect stands for pterygium extended removal followed by extended conjunctival transplant. This technique was pioneered by Australian ophthalmologist Lawrence Hurst. Over the last more than 20 years, Professor Hurst has developed a surgical procedure for the removal of pterygium, which is a marked modification of the existing gold standard technique of CAG, and it has resulted in the best results reported in the world's scientific literature. It has got three components. The first component is the incision of pterygium head and then stripping of the head from the cornea. And then he developed a technique of extensive tenons removal. This tenon is removed almost from the medial, if it's a nasal pterygium, from the medial edge of the superior rectus to the medial edge of the inferior rectus. You have to actually dissect quite a large area of tenons, almost to the superior and inferior rectus muscle, and over the medial rectus muscle extending back up to the caruncle. So this is the extended dissection of the tenons. And adequate tenon and conjunctival removal will result in visible bare sclera above and below the medial rectus muscle. We have to hook the medial rectus muscle. This technique, many times pterygium surgery is done under subconjunctival infiltration of the anesthetic agent, but this technique has, it needs a peripulvar block. We need to hook the medial rectus, pull the eye, and then we will be able to dissect the area, dissect the tenon from the area that we want to remove. So this is a diagrammatic representation. You can see the dissection is from here to here, right up to the caruncle, and the medial edge of the superior rectus to the medial edge of the inferior rectus. This whole area, the tenons and conjunctiva, needs to be removed. Second component is obtaining a very large and thin conjunctival graft, because we have removed exposed a very large area, so it needs to be replaced with a very large conjunctival graft, and then again we have to rotate the eyeball down if we are removing, we are harvesting the conjunctiva from the superior bulbar conjunctiva. A successful autograft should be virtually transparent without any tenons layer carried over with the graft. This helps to ensure that the donor site will heal with minimal to no scarring, and a repeat graft can be harvested after a few months from the same area. Actually, this is very important, because we are removing a very large piece of conjunctiva to fill that gap. We will not have sufficient conjunctiva to pull back and again fix it to the limbus, because a large area of conjunctiva is removed. So we have to be extremely careful in removing that, so that it reepithelializes on its own without pulling the conjunctiva and fixing it again to the limbus. And again, after a few months, it will reepithelialize, and the same area can be used to harvest another graft if needed. The third component is reconstruction of the pterygium site by its large conjunctival autograft to obtain optimal cosmetic result. Now, there are some cons of this technique. The first is, it's a very long procedure. It takes around 1 hour time. It needs a peribulbar anesthesia. It requires a surgical assistant. It's difficult to do it alone. And it has a structured learning curve, how much tenons to remove, and harvesting a very large conjunctival graft. It does need some practice, and it should be attempted in primary pterygia first, because recurrent pterygia are difficult and we don't know how far we have to dissect. These are some of the pictures of Dr. Hurst, who had done this. This was a primary pterygia case. This is again a few pictures. This was a primary pterygia. This was a recurrent pterygia, and this patient had surgery almost 10 times, and this was done with the perfect technique, and this is the outcome that we can see. A number of studies by Lawrence Hurst has been published. In 2008, he published in primary pterygia about 250 patients, which were followed by for more than 1 year, and there was 0 recurrence with this technique in 2008. Then again in 2009, he published a report with 111 patients with recurrent pterygia, and they were also followed up for more than 1 year, and again in his series there was not a single recurrence, and there was excellent cosmesis. In 2012, he had a huge series of 1,000 patients, of which the primary patients with primary pterygia were 806 and recurrent pterygia were 194. They were followed up for more than 1 year, and the recurrence rate was found to be 0.1%. And in 2020, Again, he published a report of 1,000 patients with primary as well as recurrent pterygia who were followed up for 10 years. And again, he reported 0 recurrence rate with excellent cosmesis. So, can we consider the perfect technique as the new gold standard, which was previously the normal conjunctival autograft? CAG is still considered to be the gold standard, but considering the less number of recurrence rates, less recurrence, virtually nil, can we consider perfect the gold standard? Because it provides the long term and stable results for a primary as well as in recurrent pterygium. There is 0 recurrence rate and excellent cosmetic appearance of the eye and no serious complications. The cosmetic outcomes now after pterygium surgeries have become more sensitive measure to success than recurrence rate alone. If we control the recurrence, then definitely the cosmetic value of this surgery increases manyfold. Then the next move came, not next move, simultaneously these concepts were being propagated, that the reason of pterygium is there is some problem with the limbal stem cells. It has been proposed that limbal stem cell disease is the inciting event in pterygium formation, and limbal stem cell represent the barrier to potential conjunctivalization of the cornea, and if they are damaged, fibrovascular proliferation onto the cornea as is seen in pterygia becomes possible. So we have to take care of the limbal stem cells. Mini slit is the minimal simple limbal epithelial transplant. It's a technique that was first described by Dr. Sangwan in 2012. The mini slit is a newer procedure which requires the harvesting of less limbal stem cell tissue and theoretically reduces the risk of iatrogenic stem cell disease. If we remove a very large piece of stem cell, then we leave that area vulnerable and the cornea can develop some problem because of lack of stem cell in that area from where we are harvesting. But in this mini slit, we just have to remove 1 clock hour of stem cells from the limbus. And it makes it possible to harvest the limbal stem cell from the same eye. The steps of the mini slit technique are the resection of pterygium normally as we do, and excess of tenons with conventional techniques leaving bare sclera, and then we don't use conjunctival autograft, we use amniotic membrane only. We place the amniotic membrane and with the help of fibrin glue. Then resection of epithelial limbal stem cell graft of only 2 into 2 millimeters from the area that is healthy. And what we do is we slice the epithelial limbal strip into 4 to 10 pieces. That small 1 clock area limbal stem cell is sliced into different smaller pieces. And then we align those pieces around the limbus over the amniotic membrane that is covering the exposed sclera, the bare sclera, with the help of fibrin glue. Some people have put a second layer of amniotic amniotic membrane graft over those small pieces of limbal stem cells, and some have fixed the stem cell pieces also with the help of fibrin glue on the limbus, and you finish the surgery with the placement of the soft contact lens, so that for an initial few days the stem cell pieces they remain in place. Now this is a series of pictures. Here you can see the pterygium is there. Here pterygium has been stripped and you can see the bare sclera. In the third picture in C, you can see the amniotic membrane has been placed. Now in this picture D, you can see the area from where a small strip of limbal stem cell has been harvested. It is this, the only 1 clock hour area is used, and these are the small strips, small pieces. They have been split. This small area has been split into different small pieces of limbal cell, and they are placed here. they are fixed with fibrin glue, or over them again an amniotic membrane graft can be put, and finally a contact lens, a bandage contact lens is put. Now these small pieces, they grow and they fill that area, the whole area. So even if we place them separately, there is a gap in between the limbal stem cells, they grow and they fill that area, and the amniotic membrane, they help amniotic membrane that is below that, it helps in their growth. A few studies about mini slit technique. The simple limbal epithelial transplantation, a novel surgical technique for the treatment of unilateral limbal stem cell deficiency, was published in 2012 in British Journal of Ophthalmology. Here the bandage contact lens was placed over the stem cells as described by Sangwan's initial technique. A minor ipsilateral simple limbal epithelial transplantation for pterygium treatment. Again, it was published in 2015. But it looked only at the primary pterygium excision, and a second layer of amniotic membrane was used on top of the stem cells. Then a series of 4 cases of recurrent pterygia was reported in 2018. Excuse me. Then mini slit versus conjunctival autograft fixation with fibrin glue after pterygium excision. A randomized controlled trial was done. In India, in AFMC it was done. Dr. AIOC2023 was the main brain behind that. And they, they concluded that the study group exhibited a positive trend of less recurrence with reduced post-operative symptoms and other complications. More similar studies are required in future to validate the results. Not many randomized controlled trials have been done. So now we had a perfect technique, and then in perfect technique we had to use a very large conjunctival graft. In mini slit we avoided using the conjunctival graft. We used amniotic membrane and used stem cells to cover that area. What if we combine both the techniques and take advantage of both the techniques? The complete and extensive removal of tenon, and we don't use the conjunctival autograft, we preserve conjunctiva and use anti-inflammatory benefits of the amniotic membrane graft, and replacement of pathologic stem cells with normal cells. So in this technique we are combining half of the perfect technique. We are resecting the tenons and conjunctiva from the pterygium, but we are not harvesting conjunctiva, we are not putting a conjunctival autograft, but we are using amniotic membrane graft and stem cells. So this was again Dr. AIOC2023, he did this, developed this technique, and as we say that necessity is the mother of invention, he had a patient who had undergone multiple pterygium surgeries. He had that patient had recurrence, so there was hardly any conjunctiva left, and that patient had a primary open angle glaucoma also. And when he saw that patient, initially he thought he will do perfect technique, because there was 2-3 surgeries, previous surgeries were already done. So he decided to do a perfect technique, but on examination he found that there is no conjunctiva left to harvest for such a major technique. So then he tried to combine both the techniques. He thought of using amniotic membrane graft instead of conjunctiva and limbal stem cells. So that is how this technique developed, and it is called permi slit. Pterygium extended removal followed by minor ipsilateral simple limbal epithelial transplantation. In this case we preserve the conjunctiva, which is a major advantage, especially in patients with double-headed pterygium, where if we are doing both the pterygia at the same sitting, it is difficult to get to harvest that much of conjunctiva from the same eye. in patients with glaucoma, where we want to preserve the conjunctiva for any future interventions that might that the patient might need, and if there is a history of previous surgeries where conjunctiva is already scarred or not healthy. So these are the ideal candidates where we can go for this perme slit. We dissect everything. We dissect a large area of tenons, as was discussed in perfect technique. Conjunctiva also from that area. Then we use amniotic membrane graft, fix it there with fibrin glue, and use limbal stem cells. So till now he has reported 6 cases. Dr. Alok Sati has reported 6 cases of recurrent pterygium. He has done this technique in all the recurrent cases, and he found no recurrence, no symblepharon, no movement restriction, very good cosmesis, and the most important thing was that the conjunctiva was also preserved. So till now we have reached here. No one knows what is there in store in future, how we can do it, but with the help, with the perfect technique and mini slit technique, definitely the recurrences can be reduced. And I strongly feel that now the conjunctival autograft, which was considered to be the gold standard, now the perfect technique or mini slit technique can be taken as the gold standard, and other studies should be compared with these techniques. Thank you very much.